supposed to be done, she's going to say to us that it's 10 minutes before we're done. And then I can either take questions from her from the chat that people have put in, or if somebody would like to raise their hand and do it. In other words, we'll handle that. I just believe in my heart that some of you might not have the question ready or whatever. Please don't hesitate to give questions later. And I'm sure y'all know the number one fear of Americans. This is a crazy place to bring it up, but it's not. The number one fear of Americans is not death. That's number two. The number one fear of Americans is public speaking. So you'd rather die than ask a question is basically the situation. So we know some of you don't want to be, publicly seen or whatever. So bottom line to that is you can have the questions at the end, please. And then also I would like to tell you that I have no disclosures necessary. So there's no money involved in this presentation or research or anything like that. So in terms of disclosures, I don't need to tell you anything. So let's go on, and you're going to see my slides. I want to also thank the people who have helped me. In other words, I've used a lot of slides that I've used in current presentations and history. So the one you see in front of you is a UT Health slide. Most of them will have that kind of template or background because I do work here at the university. I also want to give credit to ELNEC, which is End of Life Nursing Education Consortium. And that's a group of nurses across the world that look at living life to the fullest and helping people do that. So hospice and palliative care are huge with this end-of-life care from nursing. So you'll see a number of slides that are there, and also VITAS, some of the hospice organizations. So I want to thank everybody for that. So bottom line, let's look at some objectives that we're going to be going through. And for some reason, my objectives won't move. That's not funny, is it? Okay, so there we go. Okay. I'm not sure why that happened, but okay. So the objectives, looking at just today, we're going to discuss some important roles that caregivers play in identifying and really trying to help manage the symptoms, the situation for their loved one at the end of life. And also, what interventions can we make? So the roles, what's going on? How about some interventions that we can help older people with, those at the end of life who have delirium? What's going on that we can have interventions that would be appropriate therapies and so on? Identify psychosocial issues that might come up throughout this. And already that's another thing we could spend an hour on. And also determine some of the spiritual considerations, issues, and so on. So in looking at this, I don't know you. You heard about me and some of my background, but I didn't know exactly how to put this. Hang on. Okay, I didn't know exactly how to do this. What was I going to say to you, etc. So I didn't know where to begin. So the best thing I think to do is begin with the end in mind. That's what Stephen Covey says. He's the one that wrote 7 Habits of Highly Successful People. And so he says, start with the end in mind. So ladies and gentlemen, I'm not sure what the end in mind is for you. I'm going to imagine that it's about best care. It's about best care for the person that you love so much that you've been taking care of for 2 days or 20 years or whatever it might be. So best care, not only for that loved one that you're caring for, but you, the caregiver. And I can tell you that I'm sure many of you in the audience will say, yep, the caregiver is the one that gets the least care. She's going to get her hair done. That was 3 months ago. She was going to go to church. That was 2 months ago, etc. So we're going to be talking about that because we know that caregivers are often family. And when I use the word family, I'm using, if you look in the dictionary, some years it was related by blood, marriage, or adoption. Well, that's not all it is anymore. So I'm going to use the term significant others and family interchangeably, because I don't know about you, but maybe you don't have a brother, but oh yeah, that guy you've known since you were in first grade is your brother. And in the hospital or in caregiving, oh yeah, he's the one that you would want. So bottom line is family, and this whole presentation is going to be about significant others and caregivers certainly come from that. And what do we know about those people? That at end of life, they give such incredible care. So much you see on the slide there, 80% we believe is provided by the family. I can tell you, as Candace said, I've been an ICU nurse for most of my life in ER as well. And most recently, I would say in the last 10 years, I've been doing a fair amount with hospice and palliative care. And so when you look at all that we can learn from families, from caregivers, we just don't know how to help. It's because we don't know exactly what's going on Every one of you have an individual situation, and I want to honor and respect that. So looking at our goals, what goals might we have for your loved one, for the person you've been taking care of? And then also, don't forget, I'm going to keep saying it over and over, about you. What about the caregiver, or perhaps you and someone else? Let's say you and your husband are taking care of dad. It might be what are the goals of you individually as well as dad. So the family dynamics, what are they like? Let's say, again, you've been taking care of mom for the last 8 years, and now your sister comes who doesn't know very much about the care and really hasn't been involved, but boy, she wants to tell you everything. Oh, wait, what about your mother's sister? She comes and doesn't know, but she doesn't feel comfortable with that, and she wants to help.
Okay,
so what you're hearing me say is the dynamics of this family could be incredibly different for everyone. So the bottom line is, what can we do in terms of those family dynamics to set goals? Remember, ladies and gentlemen, it's all about the person. It's all about your loved one. I would tell my students and nurses in the hospital, it's all about the patient. And certainly the family is part of that word, patient. So what about the home? What about what you're dealing with now? This is looking at end of life. What have you been doing all along to be able to take care of your loved one? And now some home situations need to change because of comfort, because of, let's say, devices, let's say materials, medication, whatever it might be. We might use strategies for this person to be able to caregive as best as possible. What strategies might those include? Again, you might be working with the case manager to get that bed, to get that walker, to get things that are really done well. And then also look at safety, safety, safety. You're going to hear me talk about safety as well as talk about it. Communication is huge in this presentation. So looking then at all these goals, what kind of resources do you have? It could be, again, the case manager. It might be getting a sitter. It might be somebody that's going to help take care of you. It might be that lawyer that really needs to help you take care of stuff. I'm going to mention advanced care planning in a little while. And so it might be people on every level taking care of things that you need. What resources do you need? What might be available? What do people want to do for you, and so on. So let's look then at some aspects of care and cure and comfort and so on. We're going to start looking at palliative care through this. And so I want you to know that care and cure and comfort might all be the same. So are we going to try to have the best of both worlds? Cure them? Well, maybe so. Maybe back in the day, the diagnosis, we thought, we might be able to cure this, but you know what? Now, not so much. Not so much that we can cure. Comfort is always a big deal. Absolutely. So you see at the bottom of the slide there, I have geriatric. And so most of the presentation, I'm looking at the older population. So if you're looking at geriatrics, what about that individual at this time of his life might we need to consider? I'm going to tell you some myths and things like that later. Just because someone's old, this, that, and the other is not necessarily true. So we're going to look at those things. But in terms of, I know a geriatrician here that is just incredible. And she's also a pediatrician. And so when I refer people to her, oh my gosh, they're just so taken by the amount that she can do for them and suggest and so on. And I'll be honest with you, some of you might think, what, is that good or is that bad? What these people are saying. One of the first things I've heard many people say, including the doctor herself, is that when the patient comes in with her daughter, they take out her medications, the patient's medications, first thing. And the first thing they do is probably delete or stop a whole bunch of those, maybe half. Now, I'm not saying anything negative here, but people are often on medications too long, too many of the same ones that are sort of doing the same things, etc. So let's look at the care delivery. What are the goals again? How does the patient feel with this, that, or the other? So this, again, like I was recommending, a geriatrician and pediatrician together are, oh my gosh, the best of the best. If you could find a person that was either of those, wow, just go ahead and do that, because palliative care is the best of the best. If you walk out of here thinking nothing more, and I'll say this again to you, palliative care, if you fall asleep through this presentation, symptom management, those two words, symptom management is what you need to walk away with. That's what palliative care is. Yeah, I'll go into some detail, but pain is one of those big symptoms that people have. So pain and symptom management is what a lot of you might think about. Yeah. That's palliative care. So let's look at some trajectories of the way people go through, let's say, the living and dying process. So on the first one, what you see there is a person as time goes on, their health is pretty good, but then oh my gosh, all of a sudden something happens that, takes them right to death. It could be a heart attack. It could be a stroke. It could be an injury. It could be all kinds of things. So that's one trajectory. The one to the side of that is that health has been okay. And then all of a sudden something happens and they begin to deteriorate, and the sliding down to the death. Another one might be that they became ill and things got a lot worse. Well, got stable, got a lot worse, then more stable again, some ups and downs, but boy, every one of the downs seems like we're taking more and more towards death. Decisions, communicate it, talk about it. What really, at this point, does the patient want? Is dialysis more important? Yeah, maybe it is. Is something about surgery? No, the patient doesn't want that. I'm giving you examples of things that are real for me. I'm too busy to make up stuff. So I can tell you at the end of many of my presentations, people have said, I love your stories. Well, that's because they're real and they apply to. So for example, the man that told me, I don't want to have my leg amputated. I'd rather die with 2 legs than walk around with 1. No, I'm not. Well, sir, do you understand at this time of your life that you would be moving closer to death because the infection that you could potentially get, the fact that if you don't have I don't care. I don't want to die with 1 leg. I'd rather walk around with 2. I'm sorry. I want to die with 2 legs. I'd rather not walk around with 1. So that's just something that sticks with me forever. So yeah. And then the last one there is you have a person who over time, they become more frail and et cetera. And that's how they die. So as we're looking at these trajectories, and I've already mentioned to you palliative care, let's look at a continuum of care. Let's do that. A continuum of care that where we start with the diagnosis and we go out to death. So what you see, the one on the top is looking at, wow, we got the diagnosis and here's where we go. We're going to try, do everything we can to cure. We're going to stay on top of the pain and symptom management. We're going to do all we can to help this patient have a prolonged life. And let's be honest, ladies and gentlemen, sometimes that causes a little suffering. Sometimes that is not comfortable for the patient. But yep, we decided that that's what he's going to do. We're going to push. And yeah, okay, now we're at Medicaid. Now we really are at hospice. We've exhausted all the benefits and whatever. We're doing the best we can, but he's still got CPR. I mean, there's lots of things that we're just not comfortable with. And then he dies. So that's the top one. That's kind of the old continuum. And now what we totally recommend is at the time of diagnosis, how about let's start looking at the treatment modalities. Let's look at the life prolonging care delivery situations and strategies. And then also at the same time, start looking at palliation. Let's start looking at palliative care and what can we do to help this person with their pain and symptom management all along. And then as we're going through this, we might say, we are getting to the point where probably we need to stop that kind of invasive technology or whatever the case may be. What is it we can do to help this individual? And so hopefully you're seeing on this continuum of care that's going along at the same time. And then look how early on this trajectory is looking at hospice care is earlier. I can tell you, ladies and gentlemen, as a nurse, it's very frustrating to say to a physician, let's go ahead and start palliative care. No, we're not going to do that. She's not that bad. No, I'm not talking about hospice. I'm talking about palliative care. I'm talking about doing the symptom management that we all know about. No, because then they're going to cut off this procedure. Now they're going to, okay. So the doctor is equating pain and symptom management coming under hospice care, under palliative care. It's all confusing. So he sees that hospice and palliative care are the same, and they are not. And so I'll compare them for you in just a minute, but I think it's really sad in our country how people are not getting, both of those are fabulous. And I can tell you hospice care is often in this country, and it might be different. I know a lot of you are in Arizona. A lot of you might be dealing with things different from me in Texas, but I can tell you it's very shameful that people are not enrolled in hospice programs 6 months out, 6 months before the time of death is projected. That's when most people would get enrolled in hospice, or we would like to see that. What if they live 7 months? That's okay. It's the point, and we're looking at when do we think that their death is coming. So in 6 months, they could be in hospice care and so on. I'm sorry to tell you, but I had a lady the other day that told me her mother was enrolled in hospice 99 minutes. I'm going to say that again. 99 minutes her mother was in hospice care before she died. That is shameful. And she said, now that I know all that could have been given to my mother, I'm just sick over it. So then what does that take you into? The death. And then you see on the slide, bereavement care is something we really need to look at. So what I hope you're hearing me say loud and clear is palliative care and hospice care together. Oh my gosh, working with the situation from the beginning. Wouldn't that be nice? So then let's look at palliative care. Yeah, I told you already, it's looking at kind of trying to improve that quality of life for the patient and the loved ones who are facing these problems, the situations that are associated with this life-threatening illness that they're dealing with. So what we'd like to see is early. We'd like to prevent. We'd like to relieve suffering as much as we can as early as possible with our great assessments, and trying to treat that pain and symptoms as best as we can. And there's probably all levels of aspects here: spiritual, emotional, psychological, psychosocial, et cetera, et cetera. So the earlier, the better. Hopefully that's what you're hearing from this. Also, I told you I would do some comparing. So looking at hospice and palliative care, looking at specifically palliative care, we can see it throughout the course of the illness, absolutely. And most people see hospice, if they see it this early, I hope to goodness, yes, 6 months out is what people are thinking it would be a good thing to do. And when you talk to the patient about it, they might say, am I that bad? Etc. So when we're talking about caring for you, the caregiver, wow, some of these things are really hard in terms of dealing with mom and her situation. Now you're facing more, and her questions are bringing on more pain and all that for you now. So once again, how are you trying to take care of yourself and your loved ones and so on? Like we talked about family dynamics. What's going on in this? So with palliative care and hospice early on would be great. And I already showed you the slide of let's start palliative care way back there. Okay. And then in terms of where it's done, you can have palliative care really in any setting. And then in hospice, yes, many of you might know about inpatient hospices. Sometimes it's just in the home for a certain individual. Some it may start in hospital and then it goes to home, etc. I can tell you that whenever my dad was in the hospital before he died, we decided that the inpatient hospice was best for him. We took him there and oh my God, it was so incredibly different at the hospital. And I'm not saying anything negative. As a nurse, I know all this well. And in this room, I get to take off my mask, but we always have a mask on. So with all the stuff that was going on with COVID, my mom and I had to be tested at least every week before we could go in to see my dad. In most situations, you had to have one person only. Now I'm a nurse and I'm in the hospital all the time, so I could go in and out. But by and large, my mom was the only person who got to be in there. Well, when we transferred my dad to the inpatient hospice, oh my gosh, 3 people could be there at the same time. And my grandson was only 8. And the nurse said, you know, you can go. So that was 4 people in my dad's room, loving on him and helping him. So I can tell you, inpatient hospice, I can't tell you enough about how wonderful they are. The staff is incredible. They're very committed, etc. So consider that as a potential choice for your loved one as well. Also allowing the curative therapies, absolutely. In palliative care, we're going to do the best we can to, again, cure if we can, treat these things in terms of pain and symptom management. And then in hospice, let's look at what the patient decide about this life-sustaining treatments. As I told you earlier, maybe certain surgeries. We've had people talk about dialysis, certain tubes, gadgets. Some of you may know about PEG tubes. Should we be feeding this individual at this time? When we look at goals, when we look at plans of care, etc., what about feeding? And I can tell you that people have said to me, and in the especially ICU, you people are starving my mother. I can't believe you're not giving her any more to eat. What about some tube or something? Okay. Also, they say something like, I can't believe you're not even giving her any water, any volume. We've been running the IVs, but that's all. And so when I've asked people, how much have you been around death? I've had people say, not at all. I had one woman who I said, have you ever had anyone in your family die? No. Have you ever had the occasion to be with anyone when they died? No. I didn't know what to say. I said, have you ever been with a puppy? She said, oh, yes. And then went on about her dog that died and was crying and etc. And I said, okay, then what you're expressing to me is that you have been in a death of a loved one with your pet that meant a lot to you. And she said, oh my gosh, I'll just never forget. And so her bereavement, you could tell, was right there. And so I started asking questions. And I said, when your dog was so close to death, did you try to feed him? Oh, God, no. Why not? Well, I mean, he had this stuff around his mouth. I don't know, it was like kind of like bubbles and like kind of frothing of it was. And I said, so you wouldn't feed him now? And is that because it would make him uncomfortable? Yes, it would have. Okay, so what you just said to me is you wouldn't push food on your loved one, which was your dog, when he was dying. And she said, that's exactly true. And I said, that's exactly how we treat adults, people, children, that however we want to categorize in patients, that's how we treat them, as kind and comforting as we can. And I can tell you, if you cut off all that, if you cut off the food and water, if you will, then that tells the brain certain things. If you start it again, oh my gosh, the pain and the issues in the brain are something. We see people suffering, if you will, more. So there's a thing called azotemia when you're looking at taking away all that fluid and all that the kidneys have to deal with and so on. Wow, the person has a lot more comfort and a lot less suffering. So when you're seeing this end of life and included in life and so on, I want you to see that we're worried about, concerned about all of this, but at the end of life, people need to understand what all we can do in hospice and so on. And then the last one's in terms of payment. There's, in some situations, palliative care is covered, but not a whole lot. So philanthropy and fee for service and what's the person's going in for that treatment, et cetera, might be covered by insurance. But strangely enough, Medicare, Medicaid, a lot of the third-party carriers for insurance, oh yeah, they cover hospice just fine. So hopefully that's something you'll experience. So when you look at palliative care, what's the difference in that and good health care? Well, just look when people say, oh, she's gotten good health care, et cetera. If you just look that up, it's typically about insurance and money, and you really can have this covered. If you just look it up right now and Google it or whatever, you'll see that that's some of the things that are talked about, and practitioners, et cetera. It's not really looking as specifically as with palliative care. We're trying to focus on the goals of the care. What does the patient really want us to do? And therefore, what does the family, significant others want to experience? What that individual wants. We weigh the risk and the benefit of the therapies that we want to give in light of the goals that the patient has told us. And as I told you earlier, communicate. Let's talk about what we want to have done here, expressing our goals collectively, and then maybe individually, maybe day by day, hour by hour, these goals can change because we want our loved one to be comfortable and have life closure as beautifully as possible. So what can we do? I'll mention to you 8 domains of palliative care, and we're going to mention some of these a little bit more specifically, but just as a big picture, you can see that there are structure and processes that go on in the palliation. And then what about the physical symptomatology, the aspects we need to look at with that, psychological, psychiatric, psychosocial kinds of issues, spiritual, religious, etc., cultural aspects, and so on, care of the imminently dying individual, and then certainly the ethical, legal stuff. So we're looking at all those issues. And I can tell you, I have learned so much from realizing when I told you earlier on, what is the goal? How does the patient prefer, et cetera. As an ICU nurse, I've learned so much that I didn't know about other countries and how they do certain things about the death and dying process. You have to turn the bed a certain way in these lands. I mean, it has to be a certain thing, certain candles, certain aroma, et cetera, in the dying process. Note, if this is in your home, if you're having your loved one dying in your home, which is what he prefers, fabulous. You probably know all those things, but if perhaps not, I can tell you that when earlier Candace mentioned that I started a support group here in San Antonio for people who had near-death experiences. That's one of the things I've done a great deal for many years. Why is that? Because I was in a resuscitation with an individual who came back and told us, I hate you people, etc. What you usually think about chocolates and flowers for your resuscitation efforts when the patient comes back. But no, when the individual is not happy anymore, they died for a little while, were happy for the first time, got rid of all that pain. And now you people made me come back into this god-awful, cancer-ridden, but I mean, bones are taken, you put me back in this body, and I don't want to be here. So when I'm saying to you all these aspects, all these domains and so on that people are telling us about, it's totally amazing. I know that I've opened a door for some of you. This near-death experience thing might be way out there, but I would like to say in honor of you, I think there's about 60 something of you in this, but I've presented all over the country in Canada about near-death experiences, and I'm an author and an editor, et cetera, about near-death experiences. And as you've heard on the International Association for Near-Death Studies, I can tell you that many people have heard about it and wonder about it, etc. Why am I even telling you about it now and saying that I want to honor you? I have done, my smallest presentation was about 6 people showed up. And the other one, the largest, was somewhere around 500. And I can tell you not once that I've given presentations have I not had somebody say to me, could I tell you about, and very quietly tell me about their near-death experience. They don't want to call it that. They'll say, I had a really interesting dream. Dream is a very safe word. And whenever your loved one is dying, they might tell you things that this moment I'm telling you could be a result of a near-death experience, which is very common that people will talk about it later. They're not afraid to die anymore. And I'm going to say that to you again later as well. People are not afraid to die after they've had a near-death experience. And you might think that is so cool after all that cancer and all that sickness, or after that stroke or whatever with this Alzheimer's and so on and so on. He's not afraid to die. Well, it's true. If he's 95 years old and he wants to go be with his wife, and yeah, that probably is wonderful. But what if it's your 5-year-old that tells you Jesus wants me to play and the angels need me to dance because that child was hit by a car and dead for a little while and came back and is not afraid to die? So we're talking about death, we're talking about end of life. And so I'm bringing other aspects of this into you. And I said about my smallest group and my largest group, and I've never been in one presentation where somebody hasn't said, I'd like to tell you about my near-death experience, or can I share my son's, et cetera, et cetera. I was doing a presentation in Corpus Christi, Texas, and there was several hundred nurses there. And at the end, you're supposed to go away from the stage, and people were talking, we're trying to move. And whenever I walked away completely, in my hand was a Post-it note that someone had put in my hand, and it said, thank you. For the first time in my life, I know I'm not crazy. And so, ladies and gentlemen, any of you in the audience who have had a near-death experience, I want you to know that you're respected and honored. And when I talk about it through the rest of this presentation, that and or about organ and tissue donation, I'm very respectful. And I thank the people who have given me the privilege and the honor to help them, work with them, and certainly know their families as well. So all that. Dying is an individual circumstance. Every person has a different one, and we all get to go there one for one. I don't know how many of us think that I'm going to get out of this one, because you're not, every single one of us. And so we all get to die. We might not think so. I was doing a presentation for American Heart Association with some children in the elementary school. And so the preschoolers, or the pre-kinders, were asleep, thank goodness, because I really didn't want to tell them about this death thing and life thing and et cetera, because it was all about your heart. That's what I was presenting on. It's all about your heart, your heart, your heart, your heart. And it was wonderful. And right when I was going to get in my car, these nuns came out and said, oh, the kids are awake. So this is 4- and 5-year-olds now. And she wants me to present all about your heart to them. And I did. And so I said, and what happens if we don't take care of our heart? And one child says, we could get sick. And I said, that's really true. And then what happens? And another child stood up and said, my grandpa got a heart attack and he died. And everyone was just silent. And the nuns all looked at me like, say something. Then I didn't know what to say. So I said, and then what happened? And the child said, with great vigor, he said, and then he went to heaven. I said, oh. And so everybody in the room was fine after that. He died, and then he went to heaven. So I don't know what that means to that family, that little child, et cetera. But what I'm saying to you is it's all personal, and how we see it is very different. And how it is for each individual afterwards is really something that could be beautiful. And we're going to have to remember helping them forever. So looking at a trajectory again, the changing roles that we might have. Caregivers, remember we're supposed to be taking care of caregivers as well. So if you look at the way this whole thing goes along the process, first we find out about something, the awareness comes to us, and we have sporadic kinds of situations that we're doing, taking mom to the doctor, getting things in order, etc. So every one of the things on here is important, kind of unfolding responsibilities that I now need to do this and that, maybe more household duties, more things that need to be taken care of in terms of safety, devices, etc., etc. Then once again, moving along, having these things that are developing in terms of care needs that the individual has. Maybe it's very personal needs. Maybe they need more help attending to themselves personally, bathing, etc., feeding, and so on. As we work towards the end of life, a lot of things change in our roles in the caregiving, and they might be too much. So in terms of caring for yourself, can you really do all that as you go along this way towards the end of life for your loved one? Can you really do it all? Does she need to have, again, dialysis? Does she need to have certain physical therapies, etc.? Could someone come in the home? Do you really need to take her, etc.? So what needs to be done? What can be done in the home? What can be done by other people? I mentioned sitter earlier, and some people have just been so thankful for the sitter that they got to come in their home who stays overnight. And that's all. I mean, she comes whenever I get to go to bed, and she stays overnight with my dad, etc. When you hear that from somebody who's just so eternally grateful, wow. So what I want you to see on this slide is exactly that, looking at the care delivery, if you will, from beginning of learning it all and being able to adapt to what we need to do, because now we're aware and we can. And what's the whole family dynamic looking at, again, about this? What can we do? And then whenever life is over, what about bereavement? What about care of the individual? And once again, going back to hospice, I can tell you a number of hospice, well, also mortuary science as well. Some of the funeral homes will have some beautiful aftercare programs for you and your family as they get taken care of, things with the funeral and so on. So I would highly recommend looking at aftercare for you as well. So looking at your caregiving roles that you have, again, individually, we mentioned the family, we mentioned each other, etc. What about the changing of the priorities? We have daily priorities, sometimes are almost hour by hour priorities that we have. So establishing them and then keeping up with them. And I'll tell you in a minute that sometimes those change, as I said, pretty rapidly. And then what about the physical environment? What about creating the most comfort, the most safety that's possible for this loved one? And maybe it's for more than one person. What about those of you who are in the sandwich situation where you're taking care of your children, also a parent who's really not doing well and getting close to end of life? Wow, that's really tough to be working on so many things in your own home and so on. What can we do to spread those roles out with somebody, supporting really everyone that can possibly be taken care of, the adults, the loved ones, etc. And also, what about symptoms? Observing the symptoms. Is that a symptom that really needs to be reported? Has the provider said, if ever this happens, blah, blah, blah? It might be the nurse practitioner that's working with you and said, if his bowel movements aren't whatever in the case may be, let's go ahead and try a different med. Let's try that. And I want you to let me know in the next 24 hours, etc. Please report anything, etc., etc. So also doing all this, the care delivery with honor, dignity, literally helping the person maintain their comfort in a dignified way. Also, emotional, physical, spiritual. How about the patient and the family? Let's look at all those things together. And then providing this all along the whole path until the death, and then after the death as well, as I talked about aftercare programs. So then looking at truly the priorities every single day, every hour. What are we doing to be able to get through this and prioritize the changes as necessary? Maybe we need to bring in another person today. Maybe this is the day that we need to think about what we were going to do next month, but not even next week. It needs to be today. So look at the changes that need to take place in the goals of care for your loved one as well as you. What can you do to be able to help all that? So When we looked at end-of-life interventions, we need to think about the fact that we need to pay attention to the pain and symptom management. I know you've heard me say that so many times, but I told you in the beginning, if you walk out of here with nothing else but saying that palliative care is pain and symptom management, it's really symptom management that we're looking at. So what can we do to be able to deliver that kind of care and accept caregiving for the patient that she wants? At the same time, what about the care for yourself? What can you do? And so these interventions, pace them accordingly, how you need to do it. Or once again, the availability, where you have to go, how you can do that for yourself and for the individual as well. And in the guidance through the whole death process, what can we do really as we're working into the close to death process and being ready for what's going to happen afterwards about post-care, what's going to happen, including the bereavement situation. As we take care of the individual, let's pay attention to the changes that they have in their normal behavior. I don't know what that really means, normal in a certain situation for you, but excuse me, just for a second, thank you. Looking at normal behaviors, what does that really mean? For this individual, let's say your dad hasn't eaten by himself for some time. Okay, then behavior for him at this point, is that normal, not eating, but having somebody feed him? Okay, that's something different. What about, as I said earlier, bowel habits? What about walking? What about other kinds of things that now, as we get closer to death, some of those things are just not possible. So at this time, normal for him is XYZ, whatever it might be. And where is he in his pain and discomfort and so on? So then looking at that physical aspects of, let's just use, for example, if we're looking at normal behaviors, this person your loved one has cancer, and you're looking at pain, you're looking at, is he having difficulty breathing? What about his weakness, his fatigue? Can he get around? It seems like he's a lot more confused. The delirium seems to be, and it could be your Alzheimer's loved one. It could be anybody in the situation that, wow, it's not really been this bad. Maybe it is the medication, maybe are the changes in his brain, et cetera, et cetera. So you're looking together with the practitioners about what can be done in terms of the management of this situation. And so is anorexia, all the nausea, vomiting, et cetera, is that really new? Maybe he's been vomiting for several days, and that's because of that new medication or regimen or whatever it might be. So he might say to you, it's just my whatever, and sort of blowing it off because he considers that normal, but perhaps it's not. Perhaps that incontinence is something that needs to be addressed. And then also you have skin breakdown and so on. So reporting is what I was asking you earlier. Should we be reporting certain symptoms and so on? So if you look at certain types of things in terms of chronic pain in an older adult, they might have things that have to do with musculoskeletal, so low back pain, what's going on with people who have osteoporosis and, arthritis and et cetera, what's going on with joint pain. So the older an individual gets, maybe this is getting exacerbated and maybe not getting them closer to death, but boy, uncomfortable, boy, disabled, et cetera, et cetera. So maybe it's the cancer care. Maybe it's something that deals with other situations. Comorbidities are multiple situations that are dealt with when somebody's older. Wow. So now you've got 4 practitioners on the case that have to do with the lung and the kidneys and the brain, et cetera, et cetera. What are we doing? How well are we doing it, et cetera? What kinds of situations in terms of that back pain should we be looking at? Should it be maybe a surgeon? I don't think so, because his spinal fusion is not something that we're looking at anymore, because that's really not something that in his trajectory would be very wise. So what is it that this individual might need best? I told you earlier that I was going to mention to you several things about myths about pain in older adults. So let's just look at these. Because somebody's older, that pain's just natural. Pain is natural. It's just the way that you go and you grow in life. No, pain is not something that you just, when you get old, you get pain. That's not necessarily true. Older people are less sensitive to pain. That's not true either. The older person doesn't report pain very well. He's not capable. Oh yeah, it might not be pain reported like you're used to or like you want to or like a certain symptomatology would expect, but the person is having pain, is trying to tell you about it. Okay. And some people will say if the person can sleep or be distracted from their pain, then it really isn't that bad. They really don't have pain. What? Yeah, they do. It's not fitting the pattern you want it to fit, but it certainly is pain for that individual. So also strong pain medications like morphine can be used safely with individuals, or can they? I can tell you that many people will say that the individual, as old as he is, he's too sensitive to narcotics. We should never use morphine. And I can tell you that that's just not true. Morphine is a good medication, especially when it's used with other medications to be able to balance out certain things is really a good thing to do. It takes the pain away. Now, let's be honest here. We know that all drugs, including oxygen, have side effects. All of them do. And one of the side effects of morphine could be that it really kind of depresses your breathing. So slowing down breathing could definitely be a result of the fact that you're using morphine. Well, as long as we're aware, as long as we're working on airway control, okay. As long as maybe dad's already on oxygen and we're having some breathing difficulty, maybe we ought to do that morphine at this point in time. But my bottom line for telling you that is certainly certain things can be used with older people. And then the second point on there is, oh no, they're going to get addicted. No, they aren't. What we're doing is using it appropriately to manage his pain. He'll be comfortable. He can rest. The deterioration of certain things and making him more disabled might be rectified just by having this pain and symptom management managed. So also people with dementia and other brain conditions, they don't feel pain. What? I don't know where that came up, but that is something that people believe. And the people with dementia or other brain conditions can't really report the pain very accurately. What? So what hopefully these last 3 slides, hopefully what you've heard me say is situations that are believed by people, but that's not fair. That's not true. And so they need to be assessed one by one. Just because somebody's X old doesn't make them fit or not fit the picture of they can have that medication or not. So let's look at some psychosocial issues. I can tell you that we need to first explore the values, the beliefs an individual has. So if the person that you're caring for, let's say it's your sister, and that she is literally deteriorating, and as y'all talked about this all along, you know that she wants you to speak for her. So the bottom line is, how would you say that for yourself? Hopefully you yourself, caregivers, hopefully you yourself have done advanced directives and you have all your information taken care of for legal and ethical and all those kinds of things to be addressed for yourself. So then hopefully for mom, you've done the same thing. And so you have that living will, which is called directive to physicians. And it's the piece of paper that when I can't speak for me anymore, the paper gets to speak for me. And it could be the medical power of attorney, the person who gets to speak for me when I can't speak for me. And that person really should be asked, and this is exactly how it should be asked. If any of you hear different than this, please tell me, because this is just not fair. When someone said to me, when my dad was really not doing well, and we were thinking about a peg and we were thinking about all kinds of things, the doctor said to me, well, what do you want us to do about it? I said, whoa, stop right there. It's not about me. It's about my dad. And so what my dad would like us to do is, that's all we need to think about. It has nothing to do with what I want. And so if you've told others, and if your loved one you're caring for now, as the caregiver that's the primary, you feel like the spokesperson, good. At least your loved one has that spokesperson. And we should be saying, mom would like it to be, I remember I've been on ethics committees in different hospitals here in Texas. And I can tell you that whenever we ask families about what should we do, what would your mom want, et cetera, I can tell you that when a gentleman said to me, when I said, but if we do this tube, if we do this therapy, it's kind of painful. And he said, oh, what's a little pain? And his sister and brother didn't care for that at all because their mom was dying. and their brother is saying, what's a little pain? Neither one of them are going to handle that at all, because the pain is not okay for mom. And just because you want it to be done, and what he wanted to do truthfully, I'll just say it out loud, the truth, he wanted his mom to be kept alive longer because her money that she was getting from Social Security, et cetera, was paying for some of his habits. So I know that sounds rude of me to say it that way, and I'm sure that that's not a surprise to many of you, but that's how some people handle things like this. So my question to you is, who should speak for me? Who should speak for your loved one, et cetera? And so what is going to make my life worth living? So if you know that your loved one, so for example, a gentleman in the hospital said, I said something to him about, well, what do you think about this? And he goes, I need to be kept alive. I don't really care what we do. I don't want to have surgery, but I need to be kept alive until my grandson is married. What? Yes, there's going to be a wedding, blah, 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 blah. Okay, well, that's fine. And so if that's what we want to do, personal, spiritual, all these kind of beliefs and so on, what about recovery for that individual? What I'd like to do is show you a picture, and that is, and I can use people's names and pictures and so on, because obviously I've asked the families, and this family gave me this picture. Mr. Kirsch was in the hospital, not doing very well, probably dying, but we didn't know for sure. He was right now okay. What happened to him, his wife is over to the side of him, and she's a nurse. And years before, probably 10 years before, they were driving. She looked down, she was driving, and she looked down to get something, I guess, off the floor or whatever, and she hit the back of an 18-wheeler. Well, she was hurt pretty bad. He was literally, he's in a wheelchair for the rest of his life. He's ventilated, as you can tell by the tubes in his throat and so on. So the bottom line, Mr. Kirsch is in the hospital. He's not doing all that great. His H&H, which is about his hemoglobin and hematocrit, they were coming down. And so we believe that has to do with bleeding. And so we're trying to figure out what the heck, the bleeding, and so on. And so that Mr. Kirsch decides that he wants to leave the hospital. He tells us this like on Wednesday night. He needs to leave the hospital because he needs to go to his grandson's graduation. And so we started asking, he had 5 doctors on the case. And so whenever we asked the doctors on the case, and I was the clinical specialist at the time, and so we asked the doctors, and some of them were like, what, et cetera. One doctor said, oh, no way, he can go AMA. Well, ladies and gentlemen, if you're looking at end-of-life care or any other kind of care, and the person goes home against medical advice, it's really not a good thing. So I was not going to advocate for that. I was going to say, let's do the best we can for this individual. He wants to leave the hospital tomorrow, which is Thursday, because Friday his grandson graduates. No, we're not going to do it, et cetera. So I talked to his daughter, who's also a nurse, and I said, please give us till tomorrow, and maybe we can get the doctors together and he can go. And she said, my dad's not going to care for this, and I'm afraid he's going to make us take an AMA. So Friday morning, all of us are ready. We've got everything engaged for this one doctor to stop it on the AMA. And bottom line, he said, you think it's the right thing to do? I hardly hear anybody say, is it the right thing to do? But absolutely. He said, all I have to ask you is, what if he dies at the graduation? Well, do you think we haven't thought about that? If he dies at the graduation, he dies at the graduation. Because, ladies and gentlemen, it's what I just told you about thinking about, looking back at this. Who's going to speak for me? What can we do? Et cetera, et cetera. And so what about the things we want and hope for recovery? All he wanted to do was go to Brandon's graduation. Well, I can tell you that he did go to the graduation. And I can tell you, in the city, it's a small city outside San Antonio. They graduated at the football field, and he had his wheelchair. He had the ventilator. He had everything there because the ambulance took him and his wife and so on. So it was absolutely wonderful. He did go to the whole graduation. He did fine. And this was obviously in May. Well, September, I got a note from his daughter, who I told you was a nurse. And she said, I want to thank you for the care you and the staff delivered to my dad, because yesterday he died in our home as he wished. And it's because of you and your kindness that he had the things he wanted to live for taken care of, and his recovery was as he wished. So thank you so much. And so I wrote back to her and said, I would love to use his picture. If you have anything with Brandon or the graduation or any kind of picture like that, I would love to have something like that to be able to show people about things like this whenever I do presentations. And she said, absolutely. So she sent me this picture. And when I opened it, what fell out of the envelope was, hang on just a second, was this picture. And I didn't know what that picture was. And the little note said, this is my dad. Brandon was bit by a snake when he was little. And Mr. Kirsch promised God that if he would let him have Brandon, that he would take care of him for the rest of his life. So ladies and gentlemen, that's what he needed to live for. He needed to live for Brandon, and he did. And you got to see the picture of the graduation where Brandon, that little boy in that chair with that big old grandpa right there, took care of him for the rest of his life, meaning for the rest of his life that he could do. So hopefully I just gave you a lot about what does it even mean and so on. Social aspects of this could be played in here. And so looking at the patient and the family, what do we do to care for them as this gets closer and closer to death? What can we do to be able to help and so on? So we know that families have situations that they would like to take care of. Significant others is what I just told you, I'm calling those. And when I worked at MD Anderson Cancer Center, I was absolutely amazed at how much I didn't know about certain cultural, spiritual, and social issues that are very important to families. As I told you earlier about death and dying and having certain things in the room and aromatherapy, et cetera, was very significant to certain individuals. So what is it that we don't know about that care delivery that we can learn from each other? And since you're taking care of your loved one in perhaps your home at closer and closer to death, what is it that they want? Socially, what do they want? Who do they want? What kinds of things are important? I can tell you financially, some people are very worried when they're getting closer and closer to death. They're worried about the finances of their family and so on. What's the role of this individual? If this individual dies, what is everybody else going to do? Who's going to take over those issues of economics and so on? I can tell you that one gentleman told me, I'm not having that surgery. It would take, they've told me how much the whole thing would cost. It would take all the money I have to be able to have that surgery. And I'm here to tell you that's for my son's college. No, I'm not going to have the surgery because if I do, I will exhaust our funds and my son will not be able to go to college. So it's those kinds of aspects that you want to look at. What kind of caregiving issues does that person think of, the patient? Because we're looking at his preferences as well as us, and also taking care of yourself. I told you that I would mention advanced care planning towards the end of this presentation. And certainly it's one of the most important things, and I could have said it way up at the beginning. So advanced care planning is looking at what is it that the patient wants in terms of going ahead. So in other words, it's the cornerstone of high quality palliative care, looking at what is in terms of quality of life, looking at what the patient wants. And so can we do this whenever the person's before their dementia has progressed? And I know in our Caring for the Caregiver program, we look at that a lot. Those of you who work with Alzheimer's, work in any of the agencies or so on, I understand some of you are social work case managers and other therapy type of individuals that work with dementia patients and so on. Could we get some of this advanced care planning done sooner than later, before the individual is progressing? And then certainly that will save us at end of life situations that we'll be able to take care of. So the caregiver knows exactly what to do. They want to expect the right things. And so literally, if you have advanced care planning in all of our situations all over the country, when a person goes into the hospital, we, meaning somebody at the hospital, sometimes it's admitting, sometimes it's nursing, sometimes it's clergy, et cetera. It could be social work as well. Do you have an advance directive? And if the person says, oh, what? Then you probably think they don't. And then would you like to talk to whoever about that and so on? If they do, I have it, but it's at home or it's in my safe deposit box or whatever. Well, that's no good. How can we use something that we don't even know what it says? So the formal advance directives really need to be done. And that healthcare proxy issues. We need to know all of those. I can tell you that on a personal level, whenever I was in Houston, working at MD Anderson Cancer Center, this has been 10 years ago now, I was walking to the gym and I got hit by a car. So I wasn't in a car, I was in my body, and I was hit by the car, and I should have died or been paralyzed. Everybody that saw me, all the nurses that came to see me, said they told other people not to go see me because they knew I would die or be paralyzed. And I'm not. But one of the things that bothered me afterwards, because I'm a pretty educated nurse about this kind of stuff, and my advance directives were not honored. I can tell you that when I got divorced, I decided that I was going to choose people to be my advance directive people. So that means medical power of attorney. And so I have 2 nurses that are named very clearly that are my advance directive people. So that means they're my medical power of attorney. And I'm in Houston, Texas at the time. Those people live here in San Antonio because this is my birthplace and then where I've worked most of the time and so on. No one called either one of them. I didn't want my children to have to make decisions. I didn't want my parents to have to make decisions if I ever ended up in a situation where I was getting close to death or whatever. And so I'll be darned. I'm unconscious. I'm unconscious for 3 days and in the ICU, and I'm in the hospital for a month. So I can tell you that nobody asked my advance directive folks. So a medical power of attorney never got to say anything. So the reason I'm telling you my story is because it happens all the time. Even for those of us who are educated about it, know we do the best we can, but then all of a sudden it doesn't get taken care of. So you, caregiver, push hard and make these kinds of things happen, not only for your loved one, especially if you can do it early on in a dementia story where they're cognitively aware enough to be able to make decisions and go from there. So I can tell you, I can't say enough about advanced care planning, and it is in programs all over the place now. I'm sure where you are as well. So I can tell you that older individuals, older folks can make decisions even if maybe you can't even understand what they're saying. If it sounds kind of strange to you, it might not be the language that you're wanting them to say, answering the question appropriately. Even though they might not be well educated, they kind of know what they want in some way. Maybe they're handicapped in some way. They don't know how to tell you. Maybe they're deaf, etc. So what I want you to see on this is that even if individuals have any of these debilitations, they often can tell you or relate to you how they want to be treated in certain situations. So you see the picture there, the woman is being asked by her daughter, what exactly, etc., does she want, and so on. So what about spiritual aspects? And I'm not talking religion. It might be religious, but what I've learned from many patients, and especially with all the near-death experience work I've done, I can tell you that people will say, oh, I'm not religious, but a priest told me that one day. He said, I can tell you from being in a near-death experience that I've come back knowing that it's really not about all the doctrine and dogma and all the things that I used to do and teach and so on. It's all about love and knowledge. I said, really? He said, yeah, it's a very spiritual situation that it's all about love and knowledge. And many people, no matter how old they are, say that across the world. And so the rules and the dogma and the doctrine and so on are not as special and important as I'm saying that about that in this situation, because it could be about a child or an adult who goes to, the word is heaven. For some people, they say they went to a bright light, and some people went to heaven after the bright light, etc. So I won't go on about a lot of near-death experience stuff here, but I will tell you that as your loved one is getting closer to death, he or she may have all kinds of things to tell you that you really don't understand. And I just told you, they can make decisions, even if it's not the language you're used to. So for example, if a person says, I saw him, and then you ask who, sometimes they test you out to see, or they know that you know God or Jesus or Buddha or whatever. And other people will say nothing about the name of a person, if you will, religiously. They'll say something like, I was there in this beautiful light, I was there in this garden, whatever. And that's really where they were. And so looking at the religious part of this, it might be a figure or whatever, but other people will say the energy, the light, the source, the power, those are the deity, if you will, for some individuals. Why am I telling you that now? Because as your loved one gets closer to death, they may be talking about something regarding this issue of near-death experience. Why? Why would they do that? Well, before they had their stroke, they didn't think any of this. But when they had their stroke and were in coma for however long, and that's you have them in your home now, but in the hospital, however long ago, they had that going on and no one believed they would live. And they had an experience that really changed their entire life. And they become so calm and peaceful and etc. and are not afraid to die. So that's why I'm telling you this again about the lack of fear of death. So if in fact you're taking care of your loved one at home and you're struggling with what should I do and what do they want and so on, I can tell you that if you've ever heard about nearing death awareness, it's not a near-death experience. Some people call it deathbed visions. And so if you're taking care of your loved one at home and he's comatose or he's close, he just kind of has his lucid moments or whatever, then one day he sits up and looks around the room and there's nobody in the room but you. And he looks around the room and says something to George and is talking to George. George's been dead for 8 years, but he's talking to George, which is his brother. And you think, what? And then he lays down and dies. That is not uncommon. That happens a fair amount where people all of a sudden, and I'm talking about people, yes, babies, children, adults, people who are 95 and people who are 5 months, see others before they're dying. And so I can tell you that is something that's very gratifying to individuals who are with their loved one that died and see mom wake up and talk to dad about this and will never forget it for the rest of their life. So bottom line here is I'm telling you in this spiritual situation, all this, but it could come in any of the entities here. So spiritual, psychological, all the things we're talking about. And I told you, we would also mention ethical and legal, what's going on with this individual. You see as you look at on the left-hand side, the 5 wishes. In some states, that is perfectly acceptable legally. And so in the 5 wishes, and often you can get these from hospice and palliative care individuals, you can get them in some situations, like Detox is a hospice organization here that really does a lot of work and has given people these 5 wishes. I think you can get them online in English and Spanish, but of course in Texas, we have a lot of that. So wherever you live, you might look and see if 5 wishes are available. And what's in there is if this, then that, and it's a very clear description of what I'd like. It's not like on the right-hand side, which is a legal document, which is the advance directive. So that's what people call living will, or directive to physicians is what it's called. Like I told you, it's the piece of paper that says what I want. And that's what you better pay attention to whenever I can't speak for myself anymore. So these are ethical and legal issues you might be thinking about. Also, when we look at the toll of the death and dying on the patient himself, or the family, the caregivers, et cetera, wow, it can be a lot. What about the physical, financial situations? Patients fear that it's going to be too much on their family. I don't know how my daughter can take care of me like that, or no, you need to blah, blah, blah. Financially, I don't want you to have to, so on and so on. So depending on how, again, cognitively aware, how much the patient can talk about that. You might not hear any of those things, but maybe you heard it ago, whenever. And so what fears does the patient have? It might be that they're going to exhaust others. And it also might be that when there's nothing more that can be done. And I really hate that term. I really hate that when people say, well, we've done all we can. There's nothing more we can do. That is nonsense. It's absolutely a lie, because there's always something we can do. In terms of caregiving, we can always deliver some kind of care. And so nothing more we can do might be to get her back to where she was or whatever. But what people fear, what patients really fear, is when they say nothing more can be done, will my doctor not take care of me? Will I be abandoned by the healthcare practitioners that I'm so used to working with? So yeah, people have that fear. And then how do family and caregivers adjust to the change in the situation as they get closer to death, as the death becomes the reality? And it might drain all the financial situations, as I told you earlier. What about the sandwich individuals where you're taking care of somebody else? What about spouses who are taking care of each other? Both are sick, and so on. So these are hard rows to hoe for them. Also, considerations we might make about the care delivery. What does the patient want? What does your mom want? And making her comfortable is what we're really after. But how? How does she see comfort? Maybe some of the things you're doing, she doesn't want all those people around. She doesn't want visitors. She doesn't even like flowers, et cetera, et cetera. So the bottom line is, what does your loved one prefer? Hospice is a great thing to think about. Absolutely, palliative care, we hope, is going along this whole situation. Managing feeding situations, problems. It might be about a tube. It might be about a gadget, peg tubes, and so on. What's the best thing to do? If this is really close to the end of life, maybe not having any of those is exactly the right thing to do. As I was saying earlier about helping people understand, when we stop feeding, sometimes that's the kindest thing we can do. It makes the patient die with less pain. So what about other things that are going on at the same time? Multi-systems involvement. There might be an infection here or there. Some other hospitalization may be necessary. But for whatever reason, you have to go to the hospital. Is it really necessary? Is it really necessary to cause a trauma? Because let's be honest, right now, hospitals are extremely busy. And with all the COVID and et cetera, people are dealing with, there's not a lot of beds. I can tell you in most of the hospitals here, we're having issues with bed in the facilities and so on. So what do we do? And I also mentioned to you earlier about medications and how about the pediatrician, geriatricians I was talking about, getting the patient to reduce those meds. Some of them, it's about side effects and so on. And really, do they need all that? So when we're looking at living well and then dying well, we know that it's hopefully a natural part of life is to die. But what does that mean to die well, to die comfortably, and so on? If it for all of us, it can be a great opportunity to grow and really get together and so on. But it's a profound personal experience. And I just think it's so beautiful when people tell us when they're dying, what they are doing and how it feels and that kind of thing. But many people aren't able to do such. So I can tell you that as people can slip off, and I know some people have asked for part 2, if we could have more about the actual death itself. I'm going to give you a little bit of information here in a minute, but some people have said, what's it really like at the actual time? And I can tell you once again, it's very individualized. It's very, very different. Some people, this is going to sound strange to some of you, but some people die quickly while their loved one's out of the room. And you might think that sounds terrible, but I remember for the rest of my life, I will never forget a mom. We were taking care of her child, and every day, every minute she was there, and we'd all say, go take a shower, just go get something to eat, et cetera, et cetera. I was taking care of her child this day. And so I said, what you need to do is blah, 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 just go down and get coffee. And so she said, you know what? I think I'm going to do that. I'm going to go to the cafeteria. If you need anything, just my phone number, et cetera. She is probably not on the elevator good in this child codes, and he was still to be resuscitated patient. And so we work on him, we can't get him back. And bottom line, oh my God, we forgot to call him. We forgot to get mom. We were all freaking out about it. And so when we get her back up there, she cried and cried and cried. As I told you, I was taking care of him. And I said, I am so sorry. She goes, I can't believe I wasn't here all this time. And she was just destroyed over the fact that she wasn't there in the room. And she'd been there for days and days, as I told you, hours. And so I don't know why, but I said something like, is there a reason? Can you think of any reason why he couldn't die with you in the room? And she just looked at me and kind of sucked up her tears for a second and said, oh my God, yes. And I said, I don't understand. And she said, he knew I couldn't handle it. He knew he better die real quick while I was out. And so, ladies and gentlemen, that's what some people choose to do. While whoever is out of the room, maybe it's at your home and you just went to get your hair done and Dad died. That's not, in my opinion, a coincidence. I believe people can choose when they die. That's my opinion. I'm not talking about suicide. I'm not talking about any of that. I'm talking about, isn't it odd that in the hospital, in the ICU, he's dying. No, he's not dying. And his son from Arizona gets there and dies. I find that very interesting. At the same time, the reverse. Oh my gosh, she's doing so good. She's probably going to go home today. Things are looking great. What do you mean she died? She died last night. She was supposed to be going home, etc. She was tired and she kept saying, I want to go home. I want to go home. She was not talking about Main Street. She was talking about heaven. That's the home she wanted to go to. So ladies and gentlemen, I believe it's very personal. So what can you say? And then also, what about a good death? It's interesting to me how when we look things up like this, we'll find that what the data tells us is that us healthcare practitioners, the people, doctors, nurses, et cetera, those of us at the bedside, what we think is a good death is when we provide symptom management, pain management, discussing the emotional aspects of the disease and so on. We think that's good. And sure, what does the patient say? The patient says, what I really want in a good death is control. I want to have peace. I want to have something that has to do with everything being in order that I work so hard for. I want to have all my relationships taken care of. In other words, I want my daughter to come see me who I haven't seen in 18 years, etc. So believing that my life has had meaning, that's what I really want. So it's really my purpose in getting it all taken care of. Control. That's what I really want. It's not about all the things you people think that you should be doing for me. So I think that's interesting. Barriers to quality of care at the time of death. The failure to acknowledge the limits of our medicines, what we can really do, literally and I'm not talking about medication, of just the medicine itself, the practice and so on. The lack of training for all of us. There's a lot more we could potentially be doing. Hospice and palliative care need to be really, really adhered to, and they are not the same. And what can we do to help other people understand them? I think this is one thing we can do, is give presentations and so on. What about the rules and regs? And then the denial of death. That's certainly a barrier, because some people, I guess they think they're not going. And as I said earlier, it's a 1 for 1. We all get to go. So the issues at the time of death, the final rally, as I was telling you, some people wake up and they say something and oh my gosh, then they're on their way out, etc. Some, in my dad's case, he woke up, talked to all of us. We couldn't believe it. We were so happy. We were cheering him on. And in case you have this situation in your family, I can tell you that I had talked to a doctor that was taking care of my dad at the hospital. And I said, my uncle, before he died, wanted to have the beer and the dog. That's the 2 things he wanted. And the doctor thought that was real funny and so on. So now when my dad's being transferred to hospice inpatient home or facility, this is like the next day or several days after I had talked to the doctor. And the nurse said to me, oh, hey, don't worry about the Dos Equis. And for those of you who don't know, that's a beer that we have, lots of places, but Dos Equis is a kind of a Hispanic kind of thing here in terms of beer. And she said, and the dog's okay too. What? My mom and dad don't have a dog, but my nephew does. So my dad's grandson has a dog. And I have pictures of, in the facility, my dad in his dying wishes had Dos Equis and the dog was there. So I can tell you, whatever it is for you, what kinds of language, what kinds of things can you do, visions that the person has. They might be able to go, they might not be. They might want to say goodbye, they certainly may not want to say goodbye, and so on. So looking at caregiving, all the things that we have caregivers report, that there was sleep deprivation, poor eating habits, all these things that I've listed here for you are not at all unusual. They're consequences of our caregiving, and we're glad, but not good. And so also looking at signs, literally, I told you I would show you a slide of this, what's actually going on at the time of death. So the heartbeat begins to be slower and slower. The respirations begin to slow down and so on. So it might be literally periods of apnea where they don't breathe, they don't have any heartbeat. Their pupils get fixed. Their color changes. Some people get really very blue very fast. Some people look very drained, etc. The temperature goes down. And also there's muscle and sphincter kinds of tones that relax. You might have at that point a lot of incontinence. So the bowel and bladder habits are, obviously at that time, if all the sphincter tone has changed, then it might be completely different. So then bathing and taking care of the individual and that sort of thing is going to be probably a heightened sort of need there. And then positioning of the body, there's going to be things that are going to be done in terms of respect for the culture and so on. So whatever it is in your family, your life, your culture, your awareness, etc., make sure that those things are available and so on. So having the care delivery possible for that individual, realize that rigor mortis will be setting in a couple of hours and so on. Then if your loved one is going to be cremated, that's one thing. In another situation, they might need to go to the funeral home and be embalmed. And then what about the funeral and all those kinds of things? So So what about the removal of the body from your home? So I don't mean to be too graphic in this, but people have asked about things like that. So if you look at the time of death, and how many of you will be there, since you have 8 brothers and sisters, are all of you going to be there? And is this going to be a situation where there's a ritual, or there's a song, or there's something that happens at the time? And I can tell you, even in the hospital, there's situations we've had where the individual said, the green candle has to be in the room. When my mom dies, the green candle has to be in the room. And so at MD Anderson Cancer Center, I asked nurses, are you going to let them bring the candle in? And the answer is, sure, the candle can be brought in, but it can't be lit. If in fact you need to have a candle that's lit, perhaps you could bring in one, or we have in our gift shop some with the votive candles that have like a chip, and it looks exactly like the candle is on. So making those kinds of arrangements for your loved one, and once again you, because you'll feel like you've done all that your sister wanted before she died. So offering support during the whole vigil there. Do the family members, as I just said, everybody in the family, nobody in the family, what would mom want, etc. Some of the fears that go on are, would the person be alone? Do you, the caregiver, want to be alone? Do you want to have somebody there with you, or you want nobody there for sure? You don't want anybody to know for however long, and so on. All of these decisions don't need to be made right away, but certainly it's something that not knowing the death situations would not be helpful, because I don't know what to do when. So I know I don't want to have a painful death of my loved one. So what can I do about that? So some of these things are very necessary. So I guess bottom line here, and we're starting to wrap it up, is that you want to hope for the best and just prepare for the worst. And if the best of it is that you review all the treatments and that you can prolong the life if necessary, but you want to relieve the suffering, relieve the suffering, relieve the suffering, make it safe for your loved one. And then also just be ready for the worst. What was left undone? What could we have done better? The decisions that we didn't make, or we did make, etc. What about those decisions? And then also, what about aggressive therapies? The DNR is something, and I'll just tell all of you, people have been real surprised to hear this. DNR stands for do not resuscitate. Do not resuscitate. If you look up resuscitate in the dictionary, it's about bringing back to life. So a do not resuscitate order has to be written by a doctor or on an outpatient level, out of hospital DNR. And I can tell you that DNR, it has nothing to do with care. It's about don't bring me back when I'm dead. So the only time this order can be used is when the patient's dead. It has nothing to do with pain. It has nothing to do with dialysis. It has nothing to do with feeding. It has to do with death. So when you're dead, people resuscitate you. That's what DNR is about. So I also want to remind you that you matter because you are you. You matter till the last moment of your life. And we'll do all we can to not only help you die peacefully, but also live until you die. So with that, I'd like to say thank you.